Welcome to this comprehensive clinical masterclass on adult history taking for nurses. Comprehensive health history taking is the cornerstone of advanced clinical assessment and patient-centered care. As professional nurses, our ability to conduct a structured, empathetic, and meticulous health history forms the baseline for every clinical decision, nursing diagnosis, and care plan that follows. When you encounter a patient in the emergency department, outpatient clinic, or inpatient ward, your history-taking acts as both an art and a science. It requires sharp communication skills, structured analytical thinking, and deep clinical reasoning. In this clinical masterclass, we will systematically break down every single component of the adult health history, from basic biodata and chief complaints, to the detailed history of present illness using structured frameworks like OLDCARTs, past medical and surgical histories, medication and allergy reviews, family and social dynamics, female gynecological histories, and a rigorous multi-system review of systems. By mastering every section presented on this chart, you ensure that no subtle clinical clue is missed, establishing accurate diagnoses, preventing adverse drug reactions, and delivering safe, evidence-based nursing care. Let us begin our structured walkthrough by examining the core foundational rules and overarching philosophy of effective nursing history taking. Let us explore the core foundation of our clinical practice. What exactly is history taking? It is defined as the art and science of obtaining accurate, comprehensive information about a client's health status through structured, effective communication. This history provides the indispensable basis for accurate nursing diagnoses, outcome planning, and high-quality individualized care. Now, what defines exceptional history taking? Good history taking must always be client-centered, keeping the patient's holistic needs at the center. It must be systematic and organized, following a standardized sequence so vital clues are not overlooked. It must be accurate and complete, ensuring precise clinical documentation, strictly confidential, deeply respectful and empathetic, and sharply focused and relevant to the patient's presenting situation. Pay special attention to our featured nursing pearl. A good history today leads to a safe diagnosis tomorrow. This fundamental truth highlights how thorough interviewing directly prevents diagnostic errors. Finally, let us review the universal general rules of patient interviewing. Always begin by introducing yourself professionally. Use open-ended questions to encourage rich narrative details. Practice active listening without rushing. Allow the client adequate time to speak. Show genuine empathy and respect for their cultural and personal background. Avoid interrupting while they express their concerns. Frequently clarify and summarize their statements to confirm accuracy, and always close the session by thanking the client for their trust and cooperation. We now enter the first component of the adult health history. Biodata, or identification data. Collecting accurate demographic information is far more than administrative paperwork. It establishes legal identity and provides essential clinical context for physiological and epidemiological risk assessment. We systematically collect the client's full official names, age and date of birth, which help determine age-specific physiological norms and disease vulnerabilities, sex assigned at birth and biological sex, marital status, nationality or tribe, and religious affiliation, which informs bioethical considerations, dietary restrictions, and treatment preferences. We record their occupation, which reveals potential occupational hazards, environmental toxins, or physical stress, education level, which guides how we tailor our health literacy and discharge education, home and current residential address, identifying geographical risk factors or sanitation conditions, phone number and primary next of kin, essential for emergency contact and surrogate decision-making, the official hospital identification number for legal record keeping, and the exact date and time of the interview. Why is this section critical? Because establishing positive identification prevents catastrophic identification errors, while providing the fundamental demographic context required to interpret clinical findings accurately. Component number 2 is the chief complaint, often abbreviated as CC. The chief complaint represents the primary reason the patient has sought medical attention or emergency evaluation. It must be stated in the client's own verbatim words, rather than medical terminology or clinical jargon. For instance, if the patient states, I feel like an elephant is sitting on my chest. You write down those exact words inside quotation marks, rather than documenting angina or myocardial infarction. To elicit the chief complaint effectively, ask clear, neutral, open-ended questions such as, "What is the main problem that brought you here today?" Or "What made you decide to come to the clinic today?" Always record their exact statements along with the duration of the symptom, such as severe headache for 3 days. Why is documenting the verbatim chief complaint so vital? Because it preserves the patient's primary perspective, guides the immediate prioritization of nursing interventions, and prevents diagnostic preclosure by ensuring the healthcare team addresses the problem most concerning to the patient. Component 3 is the history of present illness, or HPI. This is the elaborate, chronological story of the patient's chief complaint from its very first onset to the current moment. To perform a systematic and flawless exploration of the HPI, our nurses rely on the gold standard clinical mnemonic, OLDCARTS. Let us break down each letter in order. O stands for onset. Ask when the symptom first began, and whether it started suddenly or gradually. L stands for location. Ask where exactly the pain or discomfort is felt, and whether it radiates to other parts of the body. D stands for duration. Determine how long each episode lasts or how many days the symptom has persisted. C stands for character. Have the patient describe the quality of the sensation, whether it is sharp, dull, throbbing, burning, aching, or crushing. A stands for aggravating factors. What actions, positions, foods, or exertion make the symptom worse? R stands for relieving factors. What interventions, rest, positions, or medications make it better? T stands for time course. Is the symptom constant, intermittent, waxing and waning, or progressively worsening over time? And S stands for severity. Quantify the intensity using a validated tool, such as a numeric 0 to 10 pain scale. Why is the HPI so critical? Because a rigorous OLDCARTS evaluation provides the diagnostic backbone required to understand the physiological nature, severity, and clinical progression of the illness. Moving to Box 4. Past medical history, abbreviated PMH. A comprehensive medical background reveals underlying comorbidities that significantly impact current clinical presentation and medical safety. In this section, nurses systematically query and document 8 vital health domains. First, previous acute childhood and adult illnesses. Second, previous hospitalizations, noting dates, locations, and clinical indications. Third, past surgical procedures, including exact operation types, dates, and surgical outcomes. Fourth, major physical injuries or traumatic accidents. Fifth, chronic medical conditions, such as hypertension, diabetes mellitus, bronchial asthma, heart failure, or kidney disease. Sixth, history of blood transfusions, including dates, units received, and any history of transfusion reactions. Seventh, immunization status, ensuring up-to-date tetanus, influenza, hepatitis, and viral vaccinations, and eighth, preliminary allergy status. Why must we meticulously explore past medical history? Because identifying underlying pre-existing conditions exposes clinical vulnerabilities, predicts potential complications, and ensures that ongoing acute treatment plan does not compromise pre-existing systemic disease. We now examine Component 5. Medication history. Medication reconciliation is one of the single most vital nursing safety responsibilities during admission and patient transitions. You must perform a precise audit of every substance the patient ingests. For every medication, document the exact name, dosage, route of administration, and daily frequency. Determine how long they have taken each drug, and verify their personal understanding of the reason for taking it. It is critical to inquire not only about prescription pharmaceuticals, but also over-the-counter medications, dietary supplements, vitamins, and herbal remedies. Ask precisely when the last dose was taken, which is critical for timing therapeutic drug monitoring or scheduling pre-procedure drug holds. Finally, evaluate medication adherence, identifying barriers to compliance, financial burdens, or distressing adverse side effects. Why is medication history vital? Because thorough medication reconciliation prevents lethal drug-drug interactions, accidental toxicities, withdrawal syndromes, and clinical dosing errors. Component 6 focuses on allergy history. Allergy documentation requires extreme clinical precision to safeguard patients from life-threatening hypersensitivity reactions. You must separately investigate 3 distinct allergen categories. Drug allergies, such as penicillin or non-steroidal anti-inflammatory drugs. Food allergies, such as peanuts, shellfish, or eggs, and environmental allergies, such as latex, iodine, contrast dye, or pollen. Crucially, you must never simply document that a patient has an allergy without detailing the specific clinical reaction experienced. Differentiate true immunoglobulin-mediated anaphylactic reactions, such as bronchospasm, laryngeal edema, hives, and hypertension, from minor side effects, such as nausea or mild stomach upset. Document what interventions relieve the allergic reaction, and rate its historical severity. Why is allergy history vital? Because accurate allergy screening directly prevents catastrophic iatrogenic anaphylaxis, severe cutaneous drug reactions, and preventable medical emergencies. Next is Component 7. Family history. Mapping genetic and familial health patterns provides essential insights into a patient's hereditary health risks. Nurses systematically collect health data spanning at least 3 generations, including biological parents, grandparents, siblings, and children. Inquire specifically about high-prevalence hereditary and familial illnesses, including hypertension, diabetes mellitus, cardiovascular disease, stroke, various cancers, tuberculosis, sickle cell disease, and psychiatric disorders. For every positive illness identified, record the specific blood-relative relationship, their age at diagnosis, their current health status or age at death, and the certified cause of death if deceased. Why is family history essential? Because uncovering hereditary patterns allows early diagnostic screening, proactive risk reduction, and personalized genetic risk stratification long before clinical symptoms manifest. Component 8 is social history. Social history evaluates the environmental, behavioral, and socio-economic determinants of health that dictate a patient's daily life and recovery potential. Begin by assessing their home environment, safety, housing stability, physical accessibility, and who resides in the home with the client. Review occupation and specific workplace conditions, identifying physical strain, occupational stress, or toxic exposures. Assess financial stability and income concerns that could affect medication compliance or access to nutrition. Systematically evaluate lifestyle habits, tobacco use quantified in pack years, alcohol intake evaluated for frequency and quantity, recreational drug use, dietary patterns, regular physical exercise routines, and leisure hobbies. Why is social history so vital? Because social determinants of health directly shape health behaviors, treatment adherence, discharge planning, and the extended support networks required for holistic recovery. Component 9 is the gynecological history, required for all female patients. This specialized history provides critical insight into female reproductive health, hormonal status, and obstetric risks. First, document the age at menarche, which is the age of first menstruation. Second, detail the menstrual pattern, including the last menstrual period or LMP, cycle length, duration of flow, character of flow, and regularity. Third, evaluate complete obstetric history using the standardized GTPAL framework. Gravida or total pregnancies. Term births. Preterm births. Abortions or losses, and living children. Fourth, evaluate past and current contraceptive methods. Fifth, document menopause history, including age of onset or menopausal symptoms. And sixth, inquire about past gynecological problems, such as fibroids, endometriosis, pelvic inflammatory disease, or abnormal pap smears. Why is this history essential? Because reproductive health deeply impacts endocrine function, medication safety during pregnancy, surgical planning, and long-term preventive care for women. We now arrive at Component 10. The Review of Systems, or ROS. The review of systems is a head-to-toe, systematic inquiry designed to uncover unrecognized clinical symptoms across 9 major body systems. Let us proceed systematically through each system. In the general system, we screen for systemic signs: fever, unexplained weight loss or gain, fatigue, generalized weakness, appetite changes, and sleep disturbances. In head, eyes, ears, nose, and throat (HENT), we evaluate headache, dizziness, visual disturbances, hearing impairment, nasal discharge, sore throat, and voice changes. In the respiratory system, we inquire about cough, sputum production, hemoptysis or coughing blood, dyspnea, wheezing, and pleuritic chest pain. In the cardiovascular system, we evaluate chest pain, palpitations, orthopnea, paroxysmal nocturnal dyspnea or PND, peripheral edema, and syncope or fainting. In the gastrointestinal system, we screen for nausea or vomiting, abdominal pain, heartburn, bloating, constipation, diarrhea, and rectal bleeding. In the genitourinary system, we assess dysuria, urinary frequency, urgency, hematuria, flank pain, nocturia, and incontinence. In the musculoskeletal system, we evaluate joint pain, joint swelling, stiffness, muscle aches, back pain, and gait abnormalities. In the neurological system, we review headaches, dizziness, seizures, localized numbness, focal weakness, tremors, and memory deficits. And in the integumentary system, we examine for skin rashes, pruritus or itching, skin lesions, changes in existing moles, and skin ulcers. Why is the review of systems irreplaceable? Because it acts as an essential safety net, ensuring no vital symptom is missed and enabling the early detection of silent or secondary physiological disorders. To reinforce your practical clinical application, let us review the essential reference tools at the bottom of our poster. First, master the standard documentation abbreviations. B for biodata. C for chief complaint. HPI for history of present illness. PMH for past medical history. MH for medication history. FH for family history. SH for social history, and ROS for review of systems. Next, keep these core clinical rules in mind. Always begin interviews with open-ended questions. Allow the client to speak freely without unnecessary interruption. Deeply explore details using targeted clinical prompts. Always clarify, summarize, and confirm statements with the patient. Document findings accurately and immediately, and remember that active listening is just as critical as asking questions. Master powerful opening questions in your daily practice. What brings you to the hospital today? Can you tell me more about that? When did it start? How has it been since then? And is there anything else you would like to tell me? Never forget the golden formula highlighted on our poster. A complete history plus a thorough physical assessment equals an accurate nursing diagnosis and safe, high-quality patient care. You have now completed this masterclass on adult history taking for nurses. By systematically executing every component, from initial biodata and verbatim chief complaints, to structured HPI evaluation using OLDCARTS, comprehensive medical, drug, allergy, family, social, and gynecological reviews, and an exhaustive 9-system review of systems, you elevate your clinical practice to the highest professional standards. Excellent history taking is not merely a documentation task, it is an essential clinical skill that protects patient safety, prevents diagnostic delays, and establishes compassionate, patient-centered relationships. Review these frameworks regularly, incorporate the standard mnemonics into your daily practice, and share these visual guides with your clinical peers. Thank you for engaging in this educational session with RHW Systems and 3-star Visual Learning Series. Keep learning today for better nursing tomorrow.